that any better for you guys? It's kind of the same setup that we had last week, so I was kind of hoping that would be okay. Can you guys see okay? Okay, good enough. I do know, again, we are taping these, so, you know, when Sue Ellen uploads off of the iPad, it probably does come out a lot clearer for you guys, okay? Okay, I'm going to start recording here. And I'm going to go ahead and go back out of here, and we'll start from the very beginning. There is only one elbow case in here, so we will go ahead and search for that. I think it's kind of... Yes, Shalika?
Is there anything you can do to make your screen big? It's all the same size, so I can't really see.
To make my screen big.
Yeah, like normally, like when you're doing artwork and stuff, it's like just yours. I see everyone's. So I see Chelsea's name, JC, and Alyssa.
Okay, let me work on it here. And is that still small on your end? Is that helping at all, guys? Is that any bigger for you guys to see? That's to group mode, and that's to speaker mode. I don't know why this is different now than it was last week. There it goes. Okay, is that better for you guys to see? Straighten it up here. Is that better for you guys? Can you see that better? There, does that look better then, guys? Good, 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 good. Hello?
Hello, I'm sorry, I didn't get any, I was losing signal down the hall, so I
That's
just
okay.
gotta come to
That's
the-
okay, I'm just gonna close the door so it doesn't interfere with you. Okay, I'm gonna start the, okay. So we have just one elbow protocol. And even though it's labeled as an Owen's right elbow, it's technically a left elbow here. So we're gonna go ahead and pull that down. And notice that I'm gonna exit out of here. So notice that there is a right elbow protocol and a left elbow protocol, but we're gonna go ahead and slide the left elbow protocol over. And then the very first thing that we need to do with our survey is to pick our coil that we're going to use. And we're going to use that exact same coil that we did for our elbow. So that would be the Flex M. We'll hit proceed and we'll start. Now notice when I first pull up my 3-plane pilot. Okay. Oh, this is the right elbow. We do have 2 cases in here. Okay, let me go ahead and do a cleanup. We do have 2 elbows in here. I thought we only had the left elbow. There is a right elbow. And a left elbow. There we go. So we do have 2 elbows. So what's kind of nice with that is what we're going to do then is you're going to have to pay attention on your order of which side your patient is having pain in. I thought we only had the 1 elbow to pick from, but we actually do have 2. So our first 3-plane pilot, notice that this was taken with a large field of view. So if I pull this up, it's actually a 530 field of view. So what this technologist was basically doing is saying, okay, I just need to do a quick axial here to see where exactly, how far off center to the left is this elbow. Okay, so then what we're going to do is we're going to do a survey over that left side. Well, we're going to go ahead now and take an axial, a sagittal, and a coronal. So we can position those over onto that left side and get a nicer 3-plane pilot. We're going to start that. And this is our second localizer. So I'm going to page through and I can kind of see, this would be my axial here, or I can see my condyles, okay? Now over here, it looks like, it's kind of like a, not a true sagittal, but I can kind of see part of this olecranon here. And you see how it has a little bit of that C-shaped there? So I'm going to keep that as my sagittal. Let me pull this up. There you go. Is that better? Can you see? Good. Yeah, thank you. Okay, so this middle one here is what I'm going to utilize as my sagittal localizer, and I'm going to try to get a better coronal. But notice that it's not a true coronal because of how this elbow, these are just straight axial, straight coronal, and a straight sagittal of the elbow area. So as I page through these coronals, I don't have a real good true coronal, but I'm going to probably stick with leaving this particular one up here. So if I look at my paper for my practical sheet, the very first thing that I'm going to scan is a T2 axial. And then I can use these axials that I'm going to now first take to go ahead and set up for my sagittal and coronals. So that will be a help. So if I go ahead and I double click, and sometimes if you don't see that your field of view box is showing up, zoom out, because it may be way over here. And let's bring that now into our field of view, okay? And it's because we're so far off center. So what I'm going to do with my axials, and I'm going to go ahead and pull my book up here, because for their axials, they like to use between a 120 or a 140 field of view. Well, I have a 120 by 120 here, okay? Now, I'm going to go ahead, and these are my slices here, but I'm going to do axial slices. So I'm going to go ahead and position my axials where then my field of view box is a little bit easier to see. So notice that my 120 by 120 actually looks pretty good for this elbow picture. They utilize a 4 millimeter thickness at one gap. So we can, some places will use a 3 because you're getting a little bit resolution, but if we go by the book, we'll do a 4 at 1. It's on default. If you want to let it on default, that's totally fine. Default would be 0.4. We're going to change that to 1. And the coverage that I want is I want to be well above the elbow joint, because I know this is my Olecranon Fossa here. So I want to be well above it, but I have to cover through my radial tuberosity. And I know that this is my radius here, and I know that this bump that comes out, that is my radial tuberosity. So I have to include that area. So I definitely am going to need some more slices. So I ended up, I put in for 24 slices. I'm all the way through that bump, so I know I will catch where the biceps tendon inserts into the radius there. And I am well above where the Olecranon Fossa is at. If I go over here, and if I'm looking at how my arm is positioned, you know, you could argue that you'd want to angle a little bit, thinking that the arm is at a slight angle. That's okay. If you want to leave it a little straight, that's okay too. But I'm going to say it's going to lie in there at a little bit of an angle. So in the real world, I would have taken another localizer and tried to get a better sagittal and a better coronal off of these pilot scans here. But this is what we have to work with, but that is still okay, because I'm setting up for axials first. So this is a T2 weighted scan. My voxels are at 0.5 by 0.5, so that's going to give me good resolution. This is a T2, so I'm going to go to my contrast. My TE is at 100. Do I want to keep my TR at 850? Does anybody have any thoughts of what they would like to use? Okay, I like the range. And what range do you want me to type in? What's the minimum? Okay, 2,000 to 8,000. Okay. So that's going to go ahead and give me a good T2 weighting. If I look at my TSE factor. It has 3. Well, right up here it says it's going to take me 19 minutes. Well, we're not going to scan something 19 minutes, are we? And this is a T2 weighted, so we're normally around that 22 range, right? Good job, Shalika. Drops me back down now to 2 minutes and 40 seconds. So I have 100 TE, I have 22 turbo factor, and I have a TR of 2434. That's actually pretty good. And I have a time of 2 minutes and 40 seconds. This is not a fat sat, so I don't have to worry about my spare TR here. My motion, I have 3 NSA, and that's really good. If you feel like you wanted to go ahead and add a little bit more time, you can maybe go to 4. I can go over to my geometry page here and look at those again. I like my field of view. I like my coverage. Again, just make sure you get through that tuberosity. That's what I'm going to really concentrate on when I'm watching you guys set these up, okay? Now, this is an axial, and I have 2 directions of phase. I have an A to P or a right to left. Well, I know that the body is lying over here, so I do not want right to left. I definitely want my fold over to be A to P, and that is actually what it is set up as, A to P. Do I need fold over suppression? I really don't, because if I look at my A to P direction off of my sagittal here, I see no anatomy above or below that should be wrapping into my images. So I can leave fold over suppression turned off. By letting it turned off, then that means I'm going to actually utilize my NSA of 4. Okay? So pretty much I like my geometry tabs. I like my contrast tabs. And I like my motion tabs. Okay? If you felt like, and this is not a something you have to do, but if you said, you know what, I might want to turn on a rest lab and change it to be free here, and if you wanted to take a rest lab, change it back to free so I can go ahead and change it. So if I wanted to put this rest lab above, what that will help minimize is that brachial artery flow coming down into your axial images. So that might be a nice added parameter to pull on or to put on that's going to give you a little bit crisper image. It's still 3 minutes and 40 seconds, and you can go ahead and proceed. Now notice that my SAR is at this first level. So if by chance you are scanning a patient that requires you to keep your SAR in normal operating mode, you have to be aware of that, okay? And you can proceed and start. Number 2 is to set up for a stir coronal. Well, right off the bat, I want to pull up a better axial. And that's what is so crucial about doing your axials first, is because then you have a real high resolution, nice signal, hopefully they held still, image where I can page through these elbow images. And as I page through, I'm noticing right off the bat where my olecranon is at. I also, as I page through, as I get down into, I see 2 bones. I know that this larger bone is the ulna, and I know that that round bone is the radial head, okay? As I go on these slices back up, now I'm in the humerus, and I can actually see where the epicondyles are located on either end. Now, it is on this image where I can look for that thickened muscle which in my lecture I was calling it the Epicondylus muscle. And actually, as I looked it up, it's spelled with an N. It's an anconius muscle. So I gave you the wrong spelling. There's an N in it, but I think, us in the MRI field, we call it a Epicondylus, so we don't even pronounce the N. But it is pronounced with an Anconeus, anconius muscle. And I know that this anconius muscle will always lie in the lateral aspect of the elbow. So once I recognize that this is that muscle, I know that this structure over here is where my ulnar nerve is going to lie. Okay? To check that, you can page down into where both of your bones are located. And I see my ulna and I see my radius. So I do know my radius is always going to be lateral. And then I do also know then that this ulna is going to be more medial here. And again, this little tunnel here is where that ulnar nerve passes through. Okay, so just kind of pointing out anatomy here on these axial images. So if I'm going to set up for a stercoronal, okay, and again, you might have to zoom out to pull your slices over depending on how far off isocenter you are. And what I want to do then is I want to go ahead and set up for a coronal. So my coronal image is going to be parallel with my condyles. If you want to set up for your field of view first, and because remember when we have like these the angles on our slices, if you just bring it straight, you can see this would be my field of view in my coronal plane. Because again, remember, this was where I put my coronal, and it's kind of like a coronal oblique is how this localizer is showing up. This would be more of a sagittal oblique in the middle viewport. And my field of view here is a 140 by 140. And if you like that, so technically, right to left, my field of view looks good. Head to foot, my field of view actually looks pretty good too. Here's my radial tuberosity. So I'm definitely going to get where that biceps tendon attaches, and I'm well above my joint space, well above that Olecranon Fossa. If you feel like you need to increase your field of view in the foot to head direction, you can make it look more like a rectangle, because technically, if you think about it, that elbow is going to be more like a rectangle. And some people might even say that I can go ahead and bring my right to left back to this 140, or even maybe even a 120, because your elbow, your humerus, and your forearm and ulna is going to be longer head to foot than it's going to be right to left here. Okay? And I'm going to go ahead and just angle my field of view slightly, because that's kind of how the arm is laying in the magnet. So once I got my field of view set, I can now go back to setting up my slices. And again, what I want to do is be parallel with your medial condyle, medial epicondyle, and your lateral epicondyle here, okay? That makes sense to you guys, and you guys can kind of page through here to get that nice angle. Maybe you put a little bit slighter angle on it, but this is really what we are looking at. Okay, so once I get that angle, I'm going to make sure I get skin to skin. So I'm going to go from the very posterior aspect. And I'm going to need to add some more slices here. The slice thickness that our book uses for our coronals is 3 to 4 millimeter thick at a 0 gap. So I have a 3 millimeter thickness at a 0.6 gap. So I can change that to 0. And then I'm going to go ahead and add more slices. So I plugged in here 24 slices. And I'm going to need some more here. So I might add 4 more slices. Okay, so if I page through my axials here, now notice that I'm not getting any of this skin or fat here, but that would be this fat up here. And as long as I'm not concerned with that, I'm not going to worry about that. I'm going to go ahead and kind of page through where I get through all of the joint here. And am I about skin to skin? Yes. That's probably the tightest I would make it. If you feel more comfortable by adding 2 more slices to 30, I'm okay with that. Okay? So you have all of these axials. Change this. So you have all of these axials to page through. Blow that a little bit up a little bit more. Okay? So that's the axial that are the coronal slices that you would want to set up. Over in my sagittal plane, I'm going to do a coronal. And you know, basically I'm just kind of looking to see do I need to angle any different? You might be able to angle it slightly here. For your coronal looking images. So it's a stir. I'm going to go ahead and go to my contrast page. I have 4051 TR. I have a TI of 135. And I think we were using more like a 140 to suppress all of the fat. My TE is at 30. And I'm thinking if we look at our book, I don't think they have a stir, but I think we were using what? Kind of around that 40 to 50 range. Okay. My motion tab, I have 4 necks. That's pretty steep for a stir, so I'm going to go down to 2, which saves me a lot of time. I have a TSE factor of 10. Yes, Shalika? Sure. For my TR with 30 slices, the shortest TR that I can use, because I'm on shortest, is 4,126. Go ahead. You could, yep. So let me go ahead and do that. Let me change and do a range. And if you say you want a 2,000 range to 8,000 range, it's going to do the exact same thing. The shortest TR is going to be 4,126 because it's going to do it in 2 packages. So you could definitely put it on range. Some of the sites, they keep all of their TRs in a certain range, okay? TE is at 50. And I have a turbo factor of 10, and I think we were using for stirs around like a 10 to 15, so I feel like you wanted to up it a little bit. It's 3 minutes and 44 seconds. And again, if you felt like you wanted to add a rest lab, you are welcome to turn on a rest lab. And position that in or superior to your slices to minimize the brachial artery flow coming down. before I want to submit this, I have to think what direction is my phase going. And this is a coronal, but because of how the elbow is positioned in the magnet, this coronal slice is actually a sagittal orientation. Okay? So therefore, the two directions that I would have of phase would be A to P and foot to head. If you go foot to head, you definitely will need fold over. If you go A to P, you would not need fold over. And you might be saying, well, which would be best? And actually, this one could be scanned either way. I would prefer to go A to P and leave fold over turned off. But some sites will say they like to go foot to head because that is the direction that your flow comes in, but then you'd have to turn on fold over, and that's why I'm getting this, I have to turn that back on, and then I'm gonna have to change my field of view and make that bigger than head to foot. But I'm gonna go ahead and leave it at A to P and keep my fold over suppression turned off. So I like how this is set up. I'm gonna get a stir weighting. So therefore my bone's gotta be dark, my fat's gotta be dark, still ligaments and then tendons are gonna be all dark. But what I'm looking for is anything abnormal being bright. And then I can go ahead and hit proceed and scan. Now notice I'm asking you to go to viewing and to pull up and identify things. We'll do that at the end here. So I have scanned an axial and I've then scanned a coronal. So now I'm going to go ahead and put a better coronal over into my viewport here. I'm going to just magnify it down there. So this is what your coronals should look like. You should be able to get a good picture of both of your condyles, epicondyles here. The epicondyles are the most roundest part of that distal humerus. The structures here would be where we call the capitellum over the radial head. And on this side would be the trochlea that is over the olecranon here. Over here then is where we call that radial ulnar joint, and it's got a notch here, so this radius head or radial head can kind of pivot and swivel, right? But as I page through, I can see that, you know, this rounded area here is where that radial tuberosity is located. So I have a better axial, I have a better coronal, and now my last thing I'm going to set up is for a T2 spare sagittal. If I look at my protocol here, I have a T2 sagittal here, but this is not a spare. And that's okay because we can make it a fat sat. So if I just go to a T2 sagittal, a regular T2 sagittal here, okay? I'm going to pull that up. It does have this volume box popping up, but I'm going to turn that off for now. For a sagittal, we're going to be 90 degrees to what our coronal was. So instead of being parallel with those condyles, I'm now going to be perpendicular to it. Okay? And if we straighten things up here, What I'm looking for here is to set my field of view over my sagittal localizer. So my field of view foot to head says 20, and I think we were using around like a 160 or a 140. And then right to left on the sagittal here, I can go ahead and pull this down. I can bring my right to left in. Because I know I am skinnier in this direction than I am in that direction, because I'm going to go, I want to get up into my distal humerus and make sure I get all of this radial tuberosity. Okay, so my slices are going to be perpendicular then to how I set up my coronals. And I know right off the bat I'm going to need more slices. We are going to utilize for our sagittals, our book again says you can use anywhere from a 3 millimeter to a 4 millimeter at a 0 gap. So I have a 3 millimeter, and I'm going to go ahead and make my gap 0. If you let it on default, that would be fine too, because that would be 0.3. Either one would be fine. I'm going to add some slices here. I have up to about 30 slices. And if I look at my coronal image, what I'm basically going to look for is that I'm doing a nice sagittal. It says that I'm reconnecting. Okay, there we go. I think we're back at it here. So my sagittal, I just want to make sure that I have a nice sagittal going straight down through the humerus, through the ulna and radius here. That looks pretty good there. My field of view box looks good. I've got coverage good from head to foot. And I am, if I want to page through these axials, I pretty much have skin to skin. If you feel like that's way too close, I'm okay if you want to add a couple slices to feel better there, to get all of your sagittals in. Okay? So this is going to be T2 weighted fat satin. Okay, so we have to first make sure that we have fat sat turned on. So if I go to my fat suppression, it is turned on, even though it was not labeled here. And you're thinking that this is just a regular T2 sagittal. Notice under the fat suppression, it says spares turned on. If there was no fat suppression, it would say no. But spare was turned on. So this is a fat satted sequence. Okay? Our inversion delay says 100. Our spare TR is 313. And that's pretty close. If you feel like you want to up that and go to like a 105, you can do that. Okay? My TE is at 100. That's going to give me very good T2 weighting. My TR is on the shortest, and here that shortest was 10,236. So we'll go back to this range that I know, Shalika, you like to use that 2,000 at 8,000. And it changes the TR. It has to do it in 2 packages, which is 5,118 TR with the TE of 100 in 2 packages. Now, what is my echo trains here? Because my time's pretty long. So let's go up to my turbo factor, and I'm going to bring it up into like that 22 to 25 range. Still got 10 minutes. I'm going to go to my motion tab, and my NSA is up to 6. Well, I don't need that much. I'm going to bring that down to 4. It's at 7 minutes, maybe even bring it down to 3 minutes here because it's a T2 fat sat. If I look at, because a T2 fat sat is going to look similar to a stir because I'm trying to take all the fat signal out. Sometimes you're going to lose signal because you're taking the fat signal out of your picture. If you want to go back to your TE and bring this TE down to 80, you're going to give your pictures more signal. So think about that when you're doing fat sats. Your T2 fat sats, you can bring those TE, you can make those TEs a little bit lower than maybe what you would a regular T2 because of the fact that you're going to get a little bit better signal in your pictures. I went from using 100 at 70.3% and I dropped it to 80, which is still T2 weighted, and it's 91.4% signal. So I'm putting signal now back into my picture. Okay? It's 4.5 minutes, and that's actually pretty good. Again, notice that I'm on first level. So you can use first level as long as you're not using 3 of them in a row and really heating up your patient. Or if your patient has a card that says scan in normal operating mode. Okay, so again, as I'm kind of going through and I got things set up the way I want, kind of look at what your tabs are telling you. Okay, my geometry tab, we kind of skipped over voxels, but I'm at a 0.5 at a 0.6, so that is good resolution. Anything's 0.8 or less, right? Again, we talked about rest labs. Well, we can continue to use rest labs here. Minimize that brachial artery flow and position it above your slices here. Okay, you can kind of just play between those two here. Okay. 4.5 minutes looks good. Phase direction. This is a sagittal. So this sagittal, though, how it's positioned in the magnet is really in the orientation of coronal. The 2 directions of phase is right to left and foot to head. Well, I don't want right to left because anything right to left is going to be the body. So I'm going to make sure that I have foot to head on this one. I'm going to have to go back then to my field of view and bring that foot to head 160, and then I can do the 140 in my right to left here. That might make me go a little higher here. It might not even, it looks like it's not even allowing me to scan it going foot to head. Nope, it's not even going to allow me to go ahead and scan it going foot to head. In the real world, it should allow you to do that. Oh, I wonder if it's because of my coil. There it goes. It was because of my coil. It said that it was body coil. So yeah, I'm going to go ahead and utilize my foot to head. I think we had it at 140, and then we had it right to left around 120 here. There we go. again, it's still 4 minutes and 22 seconds. All of my other parameters looks good. It's T2 spare. I'm going to, at the very end, bring my volume box back in. And I'm just going to adjust my volume box. And if it doesn't allow you to bring it in, you can always change the shim align. I'm going to go just out from skin to skin. Sometimes if, like I said, if it is tricky like that, go to your shim align and say yes. It'll then allow you to position your shim box easier. I'm going to minimize air as much as I can. It's being funny on me today. I went back to my shim align and turned it back off because it was being finicky on me. Okay. There we go. So we have my shim box positioned. So what I can do then is click proceed and start. So I've basically, for this elbow, I've set up an axial, I've set up a coronal, and I've set up a sagittal. You should be able to set up all three of these planes, and if I asked you to do a different weighting, it would still be easy to set up because all you're now doing is changing your parameters under your contrast page, okay? TR, TE, turbo factor, and so forth. We're going to go to the viewing, and we're going to pull up some of these images that I just took. And I'm going to go ahead and go to a stir coronal. If you hover over this horizontal bar, it'll tell you it's an axial stir there, coronal T1, coronal stir. So this is my coronal stir set. And it'll even tell me up here in this yellow box. This was scanned at 2,300 TR with a TE of 50 and a TI of 150. 3.5 thick at 0.3 gap and a turbo factor of 11. Okay, so if you ever want to see what kind of parameters were scanned in any of these sets, you can always click on the yellow bar. It'll tell you what exactly was done. It's a coronal stir, and here will be your major parameters there. So as I page through, what I'm asking you to identify is the radial collateral ligament, the ulnar collateral ligament, and the Olecranon Fossa. Well, the Olecranon Fossa is probably one of the easiest because it's just that little hole here, right? It's right in that middle of the distal humerus. And if I page through these coronals, right off the bat, I can tell that the ulna is towards this side and the radius is here. So if I'm going to look for my radial collateral ligament, I'm going to look for the ligament that attaches from the epicondyle down to this radial head. And you can see part of it here, this little black line. If I go to the next slice, I can see it even better, and I'm going to blow it up for you here. Let me even go ahead and change this to a one-on-one here. So I'm hoping you can see on your monitor at home that there is a ligament from, this is the radial side, from the radial head up into this epicondyle on the lateral aspect. Notice right next to it is another black line. And this black line is from this epicondyle, goes all the way down past the radial head and down into this muscle. That is your extensor tendon muscle, or the common extensor tendon, that, not muscle, but the common extensor tendon that attaches to the muscles down here. On the opposite side, I can see the ulnar collateral ligament. And you can kind of page through to see which of those slices can you see it best. And I can see it here, and I can see it here. So this would be where your ulnar collateral ligament is located, your radial collateral ligament here. If I look further, I see this black line that's attaching to a muscle. That would be my common flexor tendon. Okay. Now notice how the medial epicondyle actually comes out a little farther here. On your homework, I asked you to label where the plica is. And the plica is in the elbow, what the meniscus does to our knee. And they're little wedge-shaped structures. So if you look right here, it's kind of a grayish intermediate signal here. This is where your plica is located at. Okay? One of the other things that I wanted to point out to you is when we talked about this radial collateral ligament, the common extensor tendon, remember on that lateral side is also the lateral ulnar collateral ligament. So if I go ahead and go more posterior here, here's my radius. I want to go behind the radius. I'm going to go in the other direction. So I'm going to go here. So as I'm getting out of the radius and here I'm into the ulna, notice that there is this black line that attaches to the ulna, or the ulnar bone. So this little black line is that lateral ulnar collateral ligament that kind of wraps behind the radial, here's the radial head, but behind it, that most posterior one. And then we're going to page through, and now we're into the bone and we can't see it anymore. Okay? So that lateral ulnar collateral ligament is in the posterior aspect of these coronals before we get into the actual radial head and the radius and that radial tuberosity that's kind of starting to mountain out here. Okay, now I asked you also to pull up a spare, or a T2. It's a scan number 8 here. Oh, it's actually scan number 9. So this is a sagittal. And if I go right to this C-shaped structure here, here's my olecranon. Here's my trochlea. Okay. I'm asking you to pick out the triceps tendon. I'm going to bring this down. This triceps, I know this is posterior, so this dark black line is the triceps tendon attaching to the olecranon. The radial head, well, this is the ulna, so I know that the radial head is going to be on the other side. There we go. So here is my radial head. That sits right on top of it is the capitellum. Okay. And you can kind of see again how this radial tuberosity appears and kind of bulges out like a little mountain, right? This particular case, we can see on the sagittal, we know that the triceps muscle's back here, and we know that the biceps and the brachialis muscle is here. This brachialis muscle is a very thick muscle, but remember it has a real short tendon and it attaches to the olecranon. The fluid that you're seeing all through here is a torn biceps tendon. And you can see here's part of the biceps here, here's part of the biceps up there. It's actually retracted, means it's pulled up, right? So it's not even attached to that radial tuberosity. All of this is abnormal through here. But again, to show you that the biceps is anterior, brachialis is underneath it, and then the most posterior is going to be your triceps here. I talked a little bit about that brachioradialis muscle, and that's the muscle that is right here, anterior to that radial bone. And that is it. I think we have set them all up, and we've identified the anatomy in our pictures. When you are scanning in the real world, you're going to be toggling back and forth all the time. So you're going to be over here in the scan mode, setting up slices. It's got to be running, and then over in the view mode, you're going to be looking at how your pictures are looking. Are they motiony? Do I need to, take another one, and so forth. This looks like it was an axial stir full of motion, because you can't even identify anything here. Okay. This particular image here is a gradient echo, and what it is it's a really pretty picture that looks at the cartilage in the elbow, and that is what we're looking at here, that cartilage in between our bones. So you can see the thickness of it. Radiologist likes to identify that as well. And that's what these nice gradient echo pictures give us. Any questions on an elbow? What do you guys think?